Okay, I have that it is 9 a.m. So welcome to today's Telemedicine Echo. My name is Beth Munson and I am the coordinator for this Echo. I work for Missouri Telehealth Network and Show Me at Work at the University of Missouri in Columbia. I am now going to turn this over to our facilitator, Evelyn, and she's going to get us started. Hi, Evelyn.
See you. Good morning, Beth and everyone. Welcome again to our telehealth collaborative and Echo. We've got a great presentation today, so really glad to see your smiling faces on screen. I'm Evelyn Nelson with the telehealth Heartland Telehealth Resource Center. I'd like to just start off with a few house cleaning things. Just to remember that the session's being recorded. So that we can share it with you afterwards. Your microphones are muted, but please do unmute and type in the chat as you have questions. We really want to hear from you and hear what's on your mind. We appreciate when you can to keep your cameras on as we're working on our community of learning, but we also understand sometimes that's not feasible. So to get us rolling, I'm going to introduce our hub team. I'll start off with Rachel.
Good morning, everybody. I'm Rachel Mutro. I'm the director of the Missouri Telehealth Network and our Show Me Echo program at the University of Missouri in Columbia.
Thanks, Rachel. And Tim?
Good morning. I'm Tim Davis, telehealth manager at Oklahoma State University Center for Health Sciences in Tulsa, and the state director for Oklahoma for HGRC.
Thanks, Tim. And Robert?
Hi, I'm Robert Stiles. I work with the HGRC on policy issues.
Super. And Molly?
Good morning, everybody. I'm Molly Brown. I'm the new director of the Heartland Telehealth Resource Center. Going into my second month and just joining this new team.
And Christy?
Hi, I'm from the University of Kansas Medical Center. I'm the telehealth communication manager there and also work with the Heartland Telehealth Resource Center.
Thanks, Christy. And Chelsea?
Hi, I'm Chelsea. I work with Missouri Telehealth Network.
I'm scanning through. Please speak up if I've missed someone on the hub team. I sure don't mean to. Well, with those introductions, I know we have quite a few folks on the meeting today. So we will have you, please do introduce yourself in the chat so we can get to know the folks who are joining us today. With that said, I'd like to move on to our didactic today. We're really lucky we have the trifecta of presenters today, and I'm fortunate to work with all three at the University of Kansas Health Center. So first off, I'll start off by introducing Dr. Ryan Smith, and Ryan's a pediatrician, and he's the medical director for our informatics in the Department of Pediatrics. He also directs our medical complexity clinic, and we would extend an invitation. Ryan and his colleague Emily are leading a medical complexity echo right now as well. And then we're fortunate also to have Dr. Denton Shanks joining us. Denton is a family physician as well as the medical director of innovation and clinical informatics for the University of Kansas Health System with a focus on telehealth, virtual care, and digital health. And then last but absolutely not least is Steve Kropp. Steve has been a pioneer, telemedicine pioneer here in Kansas City for over 20 years. He's director of telehealth at the University of Kansas Health System. For your bio, Steve, I looked up in LinkedIn and I just loved how you put this, that you focus on continuing to provide world-class healthcare to the populations we serve in the best and worst of times, keep calm and telemed on. So I think we're going to hear some of that today.
All right, are we ready to present? I think I'm got the first slides here, but thank you all for attending today and listening in. Feel free to ask any questions anytime, unmute. We really want to tell our story and about telehealth from the University of Kansas Health System and answer any questions and go over some provider experience. And so we can go to the first slide here. Next slide, there we go. And so really starting off with our telehealth story, it seems like now many years ago, BC, before COVID, distinctly remember really in 2019, the end of 2019, a group of us were kind of sitting around a room brainstorming about telehealth, really trying to develop a plan, kind of a 1 to 3 year roadmap for telehealth starting in 2020. And sitting around kind of brainstorming how we can kick this off, what kind of goals we should have, how many patients should we see, what percentage of a provider's time should be doing telehealth. And we had been doing telehealth for kind of rural Kansas. We've been doing the stroke and heart telehealth, some psychiatry and a little bit of oncology, but it was really amounting just to a few visits per month. We're really trying to turn a few visits a month to tens of visits or potentially hundreds of visits per month. At that time, we had developed a 1 to 3 year plan. In that, of note, really our goal for the first year was to see around 10,000 video visit patients, and maybe by the end of the second or third year to get to 100,000. And then we also had a few other initiatives on e-visits. Of note, this is really again, the health system side. On the university side, they've been doing telehealth really for 28, maybe 29 years now. I'm not sure exactly what their tally is up to, but for many years, a lot of that is grant-based and project-based. And so for the health system, we're really trying to dive into the business side and really develop a sustainable program. Again, maybe 10,000 visits in the first year. You can go to the next slide. And then, as everyone knows, COVID hit. And so really we had this 1 to 3 year roadmap. And once COVID hit, we spent the first week kind of realizing that inpatient care is going to go downhill pretty quickly. And we kind of made a decision, let's initiate our telehealth plan. We just developed it a few weeks or a couple months before that. And so we really implemented year 1 of the telehealth plan within the first 1 to 3 weeks of COVID. And so we really went all hands on deck, involved kind of the entire spectrum of employees at the health system, of course, physicians and nurses and clinic staff, but also our IT staff, our administrators, policy, kind of full spectrum. And we had really, from the provider's perspective, I mean, physicians and our nursing staff aren't trained really to do telehealth. I didn't have anything about telehealth in medical school, despite my interest in virtual care and everything. All of the education was on in-person care. And so it really took a lot to do education, especially in this very acute time. So we ended up having lunch and happy hour educational sessions where we jumped on and we trained in all of the different telehealth workflows. In the very initial, we had Zoom and Epic with separate schedules, and we had to pair them up to get the right patient onto Zoom when their appointment was scheduled. Once we had that implemented really in week 2 and 3, we integrated that together. So in that way, we were actually flying the plane while rebuilding the plane. And then by the numbers, really on go live day, we saw about 80 patients. And then scheduled for the next Monday, we had nearly 700 patients, and we met our year 1 goal of 10,000 patients within the first 3 weeks of the pandemic. And so really ramped up there. We have a schedule where we systematically went department to department across the entire health system. And really by the end of the first week or 6 weeks, had every single department doing at least some telehealth, largely thanks to the lunch and happy hours. We really tried to have it fun. People were not going out and doing things. They had a little bit of extra time on their hand. So we had happy hours, maybe at 6 or 7 o'clock at night. And we had at different times 50 to 100 to 200 people even attending these happy hours, talking about telehealth, talking about the workflows, and sharing their mocktail, their cocktail, the beer that they were drinking, and trying to have fun. And so that is really how we were able to ramp it up so quickly. Just looking here, if there's anything else, I think we can go to the next slide. And so here, just really quick graphical, by the end of the first year, again, our original 1 to 3 year goal really in years 2 and 3 was to get to 100,000 patients, and we got to 208,000 with not even a full year, because really this started at the end of March in 2020. So huge ramp up from a few telehealth appointments per week to 208,000 during the first kind of 9 to 10 months there. Go to the next slide. And here you can see our again quick ramp up and about how many patients we were seeing per month. And so in that month of April, we saw nearly 35,000 patients. Next slide. And here is, again, years ago, this is a little bit outdated. This is 2020, just a couple years ago, but really showing the breadth of really across all of Missouri and Kansas. We also really did have patients during the pandemic times, because the geographic boundaries of where a provider can see their patient during the pandemic were lifted. And so we also saw patients from Nebraska and Iowa and Arkansas and Oklahoma, and then far beyond. We have kind of multiple different clinics, oncology, our trans care clinic, and definitely many of our clinics were seeing patients kind of nationwide. And so really able to provide lots of great care everywhere. I think now handing it over to Steve.
Next slide, Beth. Very good. Dr. Shanks does a great job at kind of navigating what it took to move a system the size of KU to a point where we're able to do that many telehealth visits in a day or a week or a month. Just to give you a quick snapshot of some of the folks and the clinicians, staff, executives, providers, physicians, leaders that actually made that happen. He talked about the happy hours, and he did do a great job. Dr. Shanks was usually the one that led those happy hours. Great job at kind of taking down some of the barriers that people had up, maybe falsely, maybe rightly or wrongly, about telehealth. We removed a lot of those barriers doing those kind of relaxed times, and people engaged with us. And as you can see, with most of your organizations, those of you who are on the ECHO today, you probably have a very similar group of people who helped you make a significant lift at the beginning of COVID. So this is just a very small sample. You know their names and hours of work and lots of details that go behind each one of these positions. But all of those worked, I'm going to say, surprisingly well together. Sometimes in organizations, we don't work as well as we should together. But I think when we are all faced with a challenge, everyone shouldered the load, and it was a great experience. Next slide. So kind of not a subset, but kind of the key elements of the way that we evolved our telehealth at the University of Kansas. There's some key positions there as far as physician leadership on the left. We'll just go through from Dr. Shanks down to Dr. Sale, Keith Sale, who's our Assistant VP of Ambulatory Services. There was not a single person that came back and said, we can't do X. You know, sometimes when you start a project, whether you're a small organization or a large organization, somewhere along the way, somebody's going to go, that's not the way we've done it, or we can't do that here. And through the whole process, I don't think, and I was new to the system, so I was trying to scramble and learn the culture as well as learn some of the foundational things that they'd put in place. I did not hear one person say, no, Dr. Sale, we can't accomplish that, or that's too aggressive of a a timeline, we're going to have to extend that. It didn't happen. And everyone used the skills and the tools and the talents they had to move it forward. From Dr. Ator, our medical information officer, Dr. Powell, the folks on the inpatient side, Dr. Rudy, and then the whole group of physician informaticists and clinical and quality leadership. Some of the principles that guided us through that were active engagement, not just in the noontime or the happy hours, but in between. I mean, really just about 24 hours a day, there were people that were sharing information. We used our Volt messaging to field any questions 24 hours a day. So our telehealth team was available 24 hours a day, kind of around the clock in shifts to answer any questions that people had during the night, during the day. And I think that active engagement was critical. Flexible scheduling, I think we all, whether it's in a time of a pandemic or in just normal times, that flexibility is appreciated so much. So as you're developing your telehealth program in your facility or in your system, hopefully you encourage or have a culture where that flexible scheduling is a part of your plan. The distinct perspectives for different specialties. As you know, primary care is not orthopedics, it's not neurosurgery. So we had to take into account each one of those nuances that are part of each one of those specialties and build on some of the things that we had already had established with our telebehavioral and the mental health side of our telehealth program, and start replicating some of those, but also modifying them just slightly to some of the areas of orthopedics, neurosurgery, to do to provide the care that patients were going to have to go without if it weren't for the telemedicine component or telehealth. Asynchronous, most of you are probably aware of the synchronous, asynchronous differences, but this is one area where we still have a lot to learn in this space. We've engaged in some of this during the pandemic, but as far as us being able to record those images or have that encounter from a primary care office recorded and then a specialist take a look at that at a later time, we are just scratching the surface on that. And hopefully if you're working with outlying facilities, or if you're an outlying facility and you need additional care, I think on the Missouri side, the dermatology group and how they're addressing some of the needs across the state has been fabulous on the asynchronous side. When it all is said and done, patient-centered care is important as well as improving access. Dr. Elin Nelson mentioned something on my LinkedIn page. I think that's one of the things that I find over the time that I've been working with telehealth and outreach programs is really just giving people the opportunity to have access to high quality care regardless of where they choose to live. Next slide. Thank you. We won't spend much time on this one. Local implementation and roles. All of us know that in healthcare and especially in academic medical centers or health systems, everyone wants to see, well, what's the workflow say? What's the workflow look like? And so that every step along the way in our lean process, figuring out how that telehealth consult can be executed from the time that that patient requests or the physician requests that encounter to the point where they're checked out and the bill drops. So we took time to go through that. And this was part of that heavy lift when I talked about all the people that were working around the clock. There were multiple workflows that were developed during that time period. Some of them as a result specifically of COVID, but many of them that were kind of outgrowths from our work in COVID. We saw that, okay, this is going to impact other areas. So we all of us on this call, lived through a period of time where healthcare changed, and we will see the result of that when all of us retire and are the receiving end of some of these services that we've developed in our careers. Next slide. Moving forward, I think you've probably been involved in probably up to a dozen conversations just in the last 3 or 4 weeks about, post-pandemic, what happens after COVID, all the questions that go on. Actually was on a recording of a panel discussion with some folks from Johns Hopkins and a couple other organizations for Becker's, and they're trying to anticipate, what are we going to be looking at moving forward? Part of our program is looking at what are the alternative hours that we've exposed with telehealth, whereby physicians can manage some of these after hours occurrences, maybe not having to be at the office. Maybe they can be at home with their families. And then if they've got 2 or 3 hours in the evening where they're willing to, go ahead and engage and provide some of those services. Home and non-clinical, my goodness, think of the mass of people not just in healthcare, but in all forms of corporations and workplace that are not using commercial real estate. They're using their living room, their bedroom. Many of you right now, some of I saw are using the front seat of your car. So we know that work and productive work and quality work can be done from any location through the ideas of telehealth and virtual connections. Blended schedules, in-person telehealth, dedicated telehealth sessions. That's something that I would love to hear as far as the chat and the feedback of how many of you have dedicated blocks of time where you're providing telehealth, and how many of you have had blended schedules. That's a challenge for any organization, is finding out where is that tipping point with the volume of how those patients can be managed. Dependent on reimbursement, we know that's always a component. New healthcare policies, innovation, design, digital front door, all of those elements culminate in this idea of a virtual world. We're not constrained by walls. We try to adopt here at our health system the idea of a telehealth first or a virtual first option, so that we can start weaning ourselves from the thought process that we have to have that in-person visit to provide good care. Next slide. This one was my favorite ones. My director, or my boss, Jason Grunstrom, he took a little time and researched this and kind of put together this kind of a human interest or human impact slide just for 2022. This was through a portion of February. So we didn't have the whole month of February on this slide, but think about the total of 484,500 miles not driven, just based on 8.5 miles each way. We know that many people, they travel more than that. The travel, the PTO, all the extended cost associated with healthcare for a family that has to manage this, telehealth helps alleviate some of that. And if you are a green person, look at this bottom piece. As far as the gas, the petroleum, the fossil fuel that was consumed, 19,000 gallons of gas. So 2-month gas price, $3.12. I would love to fill my car up for $3.12 right now. So we can expand this by 90 cents or more, that $59,500. And if you take the average income, net income or gross income for people in the Kansas City area, that's a significant savings. So really appreciate Jason putting together this slide. Next one, please. Growth of telehealth. We won't spend a lot of time on this. I mean, everybody sees graphs. We all have to set goals. This is just an example of what our goal, our modest and our stretch goal is for our time moving forward. As we all have experienced in post-COVID, the focus on telehealth has waned just a little bit. And we went from seeing 1,200 a day down to averaging 600 a day in our outpatient area. So we know that those numbers are going to fluctuate, but we still try to encourage and challenge providers and patients to choose telehealth first if they can. Next slide. I think this is where I hand it off to back to Dr. Shanks.
Yep.
Thank you.
Yeah. And actually, a couple of comments back 2 slides when you were showing kind of all the effects on time off and childcare and driving around town and things. I mean, to me, this really demonstrates the effect of telehealth on social determinants of health in many ways. And so a family with kids at home, I mean, I definitely in the clinic see when a parent has to bring kind of the entire family with them to an appointment, and the effects that has on the appointment when we're trying to discuss all aspects of that patient's health in person, while other children are running around the room and things like that. And so being able to not have to take time off of work, to not find childcare, to have your appointment much more when you need it, how you need it, at the time you need it, and really bring that to the patient, to me, has a big effect on kind of social determinants of health. So just want to make that comment. And another comment from Steve's talk is when we were really in the beginning of the development of our program, and huge key was communication, because these were new clinical workflows for everybody really at the mass distribution that we were doing. And so he mentioned that we had Volt, which is kind of our one of our provider text messaging apps that we have to communicate. We also had a phone line if any provider was having any IT issues about telehealth, they could immediately make a phone call and get direct care. We also had a patient phone line to where if any patient was struggling to get onto Zoom or in their my charts or anything, they could get on. And then another form of communication actually is Microsoft Teams. We actually just had kind of rolled that out for the health system, and that was hugely beneficial to have a variety of different meetings on the development of telehealth and then continue that conversation after the meeting ended with all of the chat. And so we had all different of our team members really developing this telehealth program, often, especially for the first couple months, up until late in the night or early in the morning, still having Teams meetings and continuing the Teams chat to further develop telehealth education and the workflows and all of these different aspects. So those were really key. You can go forward now a couple slides. This to me, I mean, is all very important. We are a academic medical center, really trying to provide the best care to our community, which of course we're in Kansas, involves Kansas and involves the Kansas City area, involves the tri-state region, the multi-state region, and really both highest quality clinical care and academics together. But as you can see here, there is lots of competition or others that are jumping into telehealth. And really, Amazon now has rolled out telehealth nationwide. You can jump on, go right to your Amazon account and be in a telehealth meeting. Walmart, CVS, I mean, all of these, Cleveland Clinic, Mayo, a lot of these are really doubling, tripling down on telehealth availability, not only for urgent care needs, not only for primary care needs, but also specialty care and second opinion. And so lots is going on. And if we are not really at the forefront of driving this forward, I think it's easy to see how we can kind of get left behind. And so I think this is absolutely our telehealth rollout needs to be patient focused and patient centered, because if not, then patients are going to have easy access to any number of these different companies, organizations, and now healthcare providers. Even Best Buy, if you Google it, has bought, I think, something like 5 or 6 different telehealth companies now. So you can go to the next slide. Just really quick, a little bit on provider experience and getting through kind of the telehealth encounter. Just wanted to have a slide here on collecting vital signs, both in our workflow. Our nurse kind of goes over all of these, collects vital signs ahead of time, just ahead of the appointment when the physician or clinical provider jumps in. And so now there's just a kind of plethora of different ways to collect all of these vitals. And then our telehealth department right now is really working on remote patient monitoring project. And so all of these different devices will become even more important when we're not just trying to get a snapshot of someone's vitals at one moment, but actually be able to track that over weeks to months and monitor their medical conditions. Go to the next slide. All of the physical exam, I hear, I mean, definitely at the beginning, so many providers, even in their notes, saying physical exam was unable to be done because this was a telehealth appointment. And each of those comments really drives me crazy, because you can really do so much of a physical exam. You can, of course, be able to look at everything that you can on camera. Camera is sometimes difficult, understand that, but you can instruct the patient ahead of time to take pictures or videos of anything that they would like to show off. And so I've had patients send in a video of a hand tremor before, or a video of their family member acting or doing a certain thing. I've pictures of rashes, all kinds of things. And then you can really, during the actual telehealth encounter, have the patient move their arms, legs, palpate their abdomen. If they have a lump or something somewhere, they can feel it. They can tell you what they have to do to make it hurt or where it's tender or all of these different things. And so there's really just a lot that can be done. Education wise, I think now each physician can go to their specialty, whether you're a specialty organization, whether you're cardiology, neurology, primary care. And now during the pandemic, each one of these different departments or specialty organizations have kind of white pages on how to do proper physical exams for their department. Also on that is really the university medical school education, and now the AAMC, American Academy of Medical Colleges, I believe, has a whole document on what med students today should be learning in med school in the realm of telehealth. And so really lots of great telehealth education out there now. Next slide. And again, yeah, a little bit of the same. And so next slide. And I think right now I'm handing it over to Dr. Smith.
Yeah, thanks, Dr. Shanks. I kind of wanted to take the physician perspective as a kind of a rank and file user and someone that is part of the physician informatics team, but haven't necessarily been part of the leadership in crafting our very impressive telehealth program, which was launched in a very short period of time and yet done so incredibly well. I think, again, as we communicate to our colleagues about telehealth as important care delivery modality, it's important to kind of highlight those things that are benefits of the technology. I think both Steve and Dr. Shanks alluded to some of these benefits. Being able to have schedule and location flexibility, I think, is really important, especially as a provider, someone that has young kids that need childcare. I've had some issues with childcare at times. I've been able to pivot my appointments from in-person over to telehealth, which is a really impressive thing to have. I know for me, I've also done a few kind of on the fly telehealth encounters when I have patients that are as Dr. Nelson talked about, a good part of my clinical practice is with children with medical complexity. So those with cerebral palsy, genetic syndromes, a number of health issues and relative medical fragility. And I provide my email address to all those patients and we'll message back and forth. And when things are really going on and we're messaging back and forth, a telehealth encounter, such a great way to connect with patients and be able to kind of navigate things right in the moment. And in a kind of physical in-person model, that's something that's just not easy to get arranged. It's tough to get a provider to clinic. It's tough to get a patient to clinic. And again, like there's a lot of great flexibility that you get in providing telehealth. I think Dr. Shanks also alluded to some of these issues with social determinants that can be addressed with telehealth visits. Transportation is one of those very important things. Our practice is about 30% non-English, about 5% non-English, non-Spanish. We have a large number of refugees that don't have consistent personal transportation, have general lack of familiarity with the bus system. And telehealth, again, is this great opportunity to connect with families that otherwise have a lot of difficulty getting to a clinic. Speaking about work schedules, within pediatrics, it's a little bit different because, again, it's not just the patient getting to the appointment, it's the parent and often two parents. And I've had a number of appointments in which I've had parents connect from different workplaces while a child is with a grandparent or at school. And that provides that opportunity to bring everyone in the team together. And that kind of leads to that last thing, which is, again, telehealth provides that opportunity to bring more people to the table. And I know our palliative care teams and cancer center teams, some of the clinical service lines that have a lot of complicated discussions that are very family centered, are able to overcome a lot of difficulties in getting people together in the same room by offering telehealth services. That I know within our system, we had to navigate some privacy and regulatory issues to make that happen. But it is one of those things that is a great advantage when we're able to execute that appropriately. And I think related to all of those, I'll give you a quick little anecdote from one of my patients with medical complexity who has really severe cerebral palsy and significant neurologic deficit, is the child of a Kenya Rwanda speaker from Uganda, who we have provided Medicaid transportation, arranged that. We have had her partner with someone to take the bus, and still making those appointments have been incredibly difficult. And communicating effectively has been a challenge. And so we instituted some telehealth visits that included siblings that had greater health literacy and English abilities, had an interpreter available, had home health nursing in the home, navigating some of the issues in the home care setting. And so again, telehealth really provides this incredible opportunity when it's implemented thoughtfully to provide a lot of resources. And it can be a little bit of work to navigate all those things, but that's some of the experiences that I've had. So next slide. So those are some of the positive things that I've seen in my practice with telehealth. There's also the other side and some things that can be sources of frustration, that have been sources of frustration for myself and my colleagues. I think the number one thing that I've heard from my colleagues is retaining that concept of the primary care provider in the medical home when providing telehealth services, especially acute care telehealth services. So we have on-demand telehealth services, and those at present have kind of what I call a centralized model of staffing rather than a distributed model of staffing. So we have dedicated providers that will do on-demand telehealth encounters that are part of the greater health system and not necessarily tied to the individual primary care or other practices. And I think that one thing that I've heard from a lot of my colleagues is that there is a hope over time that a lot of these on-demand visits, a lot of these telehealth visits, asynchronous visits will ultimately reach the primary care provider the majority of the times, and limiting the centralized model of staffing. There's a lot of logistical difficulties to make that happen, and I know Steve, Dr. Shanks, Dr. Sale are really working towards kind of overcoming some of those options. But I think that's a really important thing, I think, to provide a high quality of care. And kind of Dr. Shanks alluded to, there's all of these other players in the marketplace that have a more centralized model of staffing, whether it's your Amazon or these other kind of doc in the box type companies. So I think as we move forward, as health systems, thinking about the medical home and the primary care provider is really very important. Dr. Shanks and Dr. Shanks alluded to, as well as Steve, how we schedule our templates can be a challenge. Whether or not we have dedicated telehealth clinics, which Dr. Shanks has, I don't think anyone within our pediatric practice has those clinics. So having telehealth encounters within a normal clinic schedule causes some issues. I had a 9:40 patient scheduled today via telehealth that was supposed to be an in-person encounter. They connected at 9:20, and I got a notification as we were in the middle of this talk to join the appointment. And when we're in person, we have a 20-minute rooming time and check-in time. So the expectations for attending to the patient end up causing issues. I know there's also been talk about like starting telehealth with a clinic can cause some stresses, especially in the afternoon as people are getting back from lunch, in the morning as they're getting to work. So that's one of those things that can be kind of a challenge. And I think we're not alone in pivoting to telehealth really rapidly during the pandemic. And as our ambulatory services were kind of redirected to telehealth and very limited availability of in-person appointments, as that has changed, as we have done more appointments in person, our participation telehealth has gone down, but it is interesting because, again, Dr. Shanks certainly has maintained a very robust telehealth practice. I still have a pretty profound telehealth practice, but there's a number of my colleagues that, as we've gone more in person, have dropped off their telehealth counters precipitously. And one of those things that's important is setting some expectations for what are reasonable amounts of telehealth for everyone to participate in, and making sure that everyone is all of our providers are engaged and open and trained appropriately in telehealth. Platform performance, I think, again, this is a testament to the incredible telehealth team that we have, and Dr. Shanks and Steve. I think there was a lot of issues with platform performance, both our patients connecting to our preferred platform, and then we have had a delay, and even a delay of 10, 15, 20 seconds when you're in a busy clinic, and heading from room to room can really be disruptive. But that's one of those things that I've seen improve significantly. EMR integration is something that we were able to implement pretty quickly, and I think there was a lot of gain in the provider experience, provider perspectives when that was done. One thing that I think we're still working on, but we've gotten better on, is building workstations within our clinic environment and even in our offices that are really telehealth ready. We at times did not have cameras ready in all the rooms. We had dedicated telehealth rooms in our pediatric clinic, but those rooms would be often occupied with in-person patients. So providing the necessary equipment, necessary education to use the equipment that we have in the rooms is kind of very, very important. We are moving towards providing best practices. And again, the telehealth group has been great in providing education, not just on the onset of telehealth broadening, but also as we've continued upon it. So, and one of those things that Dr. Shanks and Steve and I have talked about extent is we're probably not alone in really having a lot of stresses on our actual clinic space and clinic rooms. And telehealth it has been difficult to have these hybrid schedules where people have in-person appointments and then maybe a few telehealth appointments, because it's been tough to kind of schedule these patient rooms, which are very much in high demand. So next slide, please. And being in physician informatics, I think that the one question that is so vital to our work, and we haven't truly figured out yet, we've made so much progress in the 8 years that I've been in the health system, is how to communicate change to our providers, to our staff. Dr. Shanks and I share a lot of, and Steve share a lot of enthusiasm for the positive things that we're doing in health IT at our health system, but how we get the rank and file to understand the changes that we're making and get them to adapt to the new tools that we have is no easy thing. The lunch and learn sessions, or the happy hour and learn sessions that we instituted the advent of the pandemic were fantastic. But it also is a set of circumstances that we're hoping not to have in the near future, which is a very captive audience, as a good majority of our traditional clinical services were suspended or adjusted at the very onset of the pandemic. So we had lots of people that were captive and ready to engage in telehealth to be able to provide clinical services. But a few of those things that we've used in our health system to build communication is an EMR integrated dashboard that provides education, tip sheets, videos, even links to our lunch and learn recordings available with our EMR. Back to that education and communication, like we have this great tool, and it's probably underutilized, and we're still trying to figure out as we build things within our intranet, our website, our EMR, how we get them utilized effectively. We reorganized our educational site. One of the things that I think has been positive that's come out of our pandemic in regards to communication is daily emails to the medical staff. I think that these are still labeled as COVID emails, even though they have a breadth of other information. And I think readership has probably tailed off a little bit, but I have found, especially when the message is short, concise, and relevant, these emails can be incredibly helpful and generally have a pretty high uptake of review by providers. And of course, we have short educational videos. We have a lot of other educational activities that we've been working on to, again, not only onboard our faculty, our providers to telehealth, but also continue to kind of maximize their skills. Next slide, please. I kind of talked about setting those expectations. That is kind of best done at a health system level. So in general, and then the specifics kind of managed at a department clinical service line level. So we have been communicated that our practice should have about 10% telehealth visits, and how we distribute that amongst all providers is kind of at discretion of individual departments. I think there are some visit types that really lend themselves to telehealth more than others, and building formal processes around those is kind of critical. Next slide, please. So these are my two little monsters. And I think, again, there was this great thoughtful work and that our telehealth team has had. We've had these great conversations as part of these educational sessions. But at some point, it's important to kind of go out and ask our colleagues how this is working for them. And so about 6 months into our broad telehealth launch, we initiated a survey. The numbers were somewhat limited. About 44 total providers out of a medical staff of around 14 to 1,500 completed the survey. But it's still really important information. And even within those that completed the survey, presumed to be pretty motivated providers, and almost all, nearly 80% of them had never had a telehealth experience. When we did this survey, the majority of these telehealth visits were being completed from home. That's probably flipped the other way now. And I think one of the things that's really important from the actual experience is the great majority, I don't think I listed, about 75% of our respondents commented on that personal connection to the patient, which is so paramount in what we do, was very good or excellent. Next slide, please. These are slides that this slide, I hope, as people get the slides, will be a resource. think everyone here is familiar with the telehealth resource centers, as the Heartland Telehealth Resource Center is sponsoring this event. Sprout is research and practice effort that I've been involved in, that's initiated by the American Academy of Pediatrics, that is looking at best practices in telehealth implementation and telehealth services. As Dr. Shanks has kind of alluded to, just about every professional society has guidelines on implementation, practice of telehealth, best practices on exam. And then even more exciting is this is now a part of our healthcare system moving forward. And as to that end, we have to educate our next generation of healthcare providers, healthcare leaders on telehealth practice. And so the AAMC, the American Association of Medical Colleges, has provided competencies specific to telehealth within their IT, information technology grouping. And in a similar way, ACGME, the American Council on Graduate Medical Education, has similar competencies. And again, I hope that those attending the lecture can use some of these practice guidelines and sites as a resource. Next slide. So that's all I had. I'll pass it back to Steve, and we can just the three of us answer some questions, and then we can really briefly kind of talk about a case that we were thinking about.
And I just have a quick kind of closing remark and everything, and we can get to questions and everything. I think also at 10 o'clock here in 8 minutes, we have a tornado practice drill or something on campus. So, but I think, I mean, here in family medicine, we have a problem. And in clinic, we only have a certain number of clinic spaces, of clinic rooms, and we have lots of patients that want to get in to be seen. And in some ways, actually, telehealth can get in the way, because then you have a provider seeing someone virtually in the clinical space, maybe in a exam room that has a camera, and you're actually taking up space where someone in person could be being seen at that exact same time. And so, and the virtual encounter does not have those geographic boundaries, those wall boundaries, these type of things. And so the patient, the provider could be literally anywhere and be able to connect virtually and have a high quality clinical encounter. And I think it gets into where administrators and physicians and really the whole health system is designed to think that the gold standard is in-person care. And that's really just not the case. That's what a lot of, I mean, nearly every doctor assumes, that gold standard is in-person care, but really gold standard is meeting the patient where they're at and providing great quality care to the patient when they need it. It's not me as a patient saying, oh, my tummy hurts. Let me call the doctor's office and see when I can get in. And that's like 6 weeks down the road. That's really not great care. I can get in person in 6 weeks and have the doctor feel my stomach or something and run some tests. But really it would be, oh, my tummy hurts, I want to see a doctor. And then immediately having that doctor available, or being able to at least initiate the triage process to figure out what's going on. And that's what really virtual care can do. And so not really saying that virtual care is the gold standard, but gold standard is meeting the patient where they're at, providing the highest quality of care to them immediately when they need it. And virtual care can really help do that. Maybe that's triaged in person, but really virtual care first provides that easy access. So I'll stop there, but any questions for all three of us? And
yeah, thanks a lot, Dr. Shanks. It looks we may kind of postpone the case, and if people have specific questions about inpatient telehealth implementation, we can get to those. Rachel Mutrix had a question. How will you pivot if you will not be able to get reimbursed if patients are at home during telemedicine visit?
yeah, there's health policy and everything. I mean, I think I don't understand how that can be the future of healthcare. I think the future of healthcare has got to be virtual and digital. I mean, in so many aspects. And so we may have to pivot away from some virtual care at the end of the pandemic as all of our policymakers kind of get into alignment and figure out how to implement things. But I think at least for the time being, things are status quo with telehealth, and we're getting reimbursement and lots of gets into a really big question. But in general, I think still the drive is towards virtual care.
Just a quick comment too. I think the PHE has given us about 24 more months, a little under 24 more months to the end of 2023 to figure that out. I think, Rachel, I'm going to use an example. I know you were part of one of the summits that we had down in Jeff City, and we asked some of the legislators that were part of our lunch that day, what their thoughts were about patients actually paying out of pocket for some telehealth services. And the response was an overwhelming, oh no, patients won't do this. And we asked the question in the audience, how many people had on a Fitbit? And, there were probably 80% of the people raised their hand and said they had a Garmin or Fitbit or something along those smartwatch of some sort. So, there are certain pieces that I think the public are willing to pay for. And we know that convenience trumps quality in many cases for when it comes to low acuity things. So I think that reimbursement question you have, reimbursement is probably going to change. No doubt about that. We know that's going to happen. I think the question is it going to be a zero payment for that patient sitting at home, or is there going to be some partial payment and the patient having to pick up more of a component of that? Another question, I think I saw something in the chat about, what organizations should be preparing for next. And one of the things that I think that we all should be thinking about is how, from an administrative level, what should we be projecting? If we look up over the hill, right up to the next hill and kind of look over and see what's happening, finding those areas within telehealth and in our organizations where we can provide the virtual connection for areas that reimbursement's not quite as imperative. I'm talking about post-surgical care, where it's a bundled payment. We can do those quick checks. We can check wounds and those types of things with telehealth virtually, save time on the providers. And we know that reimbursement's not going to be an impact there because it's a bundled payment. The other thing is nursing education. I think from diabetic educators to dietitians, others that are traveling all over your campus or maybe all over a county to try to educate patients, be able to convert some of those more to a telehealth consult that would not necessarily be focused on the reimbursement for it, but you're providing good patient management, and those services can be delivered in a way and in a manner that's most convenient to not only the organization, but also to the patient. So just a couple of thoughts that I think we need to be thinking about going forward to those areas that may be lending itself to better organization and coordination of services versus just focusing on reimbursement.
I think with policies and reimbursements, you really got to think about where you want to get your care, because Amazon will, absolutely love to subsidize their virtual care and then sell you the pharmacy things, the devices and everything else. CVS would love to give you have you be seen for virtual care and then give you a coupon to go into the CVS and buy a bunch of milk and granola bars and all kinds of things, pharmacy things that you buy at CVS. So if we're not figuring this out, then these companies can provide it cheaper and to the patient. Sorry, Ryan.
Oh yeah, and Dr. Shanks, I think it's a good jumping off point, but we are very lucky to have a lot of healthcare leaders, telehealth leaders here on this call. And I think it's a good call to action to advocating for appropriate updated telehealth policy in your individual state. And I put in the chat the House Bill 2552 in Kansas, which has been supported by the Kansas Hospital Authority, Kansas Hospital Association, to push forward telehealth. And again, retain appropriate broad spectrum of telehealth services in our Kansas hospitals and clinics. And I implore everyone to investigate similar type legislation in the individual state, advocate for it on the federal level also. But again, I think there's that chance we may need a pivot, but if we all work together, I think we can move forward in legislation that addresses some of these concerns. And I think, again, we're right at time. We want to be really respectful of everyone's time. And I thought the conversation was great. But many thanks. Evelyn, do you have any final comments as we close?
Just awesome. Thanks so much for sharing your journey and all this wonderful information looking toward the future. I see we have some questions remaining. We'll try to answer those with some of the post-presentation materials that we send out, and just look forward to seeing you next month. We're lucky to have our own Robert Stiles presenting on community engagement. It's going to be neat to see how some of the patient and provider engagement complements what Robert's going to share around community. So have a great month. Thanks so much for joining us today.
Thanks so much.
Thank you.
Bye, everyone.